right, well, hello everyone, and welcome to today's NBPHE's Webinar Wednesday. My name's Ashley Mueller, and I am the Education Manager at NBPHE. So today's topic is serious illness in community education and coordination of resources, presented by Dr. Patricia Wright. So if you haven't been to any of our other sessions, we leave the chat open so you can interact with your fellow attendees. So you can say hi, where you're from, answer any questions that our presenter may ask throughout, and I can read out the answers. If you specifically have a question about the presentation for our presenter, please put those in the Q&A section, and the presenter will answer those questions at the end of the session. Also, today, before I introduce our speaker, I'd like you to know that Dr. Wright did share a compiled list of resources as a handout, so I will share that in the chat shortly, and I will also email it to you at the end of today's session. So let me introduce our speaker. Dr. Patricia Wright is a nursing professor at the University of Scranton, where she teaches both nursing and business programs. She has published numerous articles and books on end-of-life care in community and is a CPH certified person. She also serves as an NBPHE ambassador. So with that, I'd like to turn over control to Dr. Wright to share her screen and the presentation today. Dr. Wright, it looks like your audio cut out. Oh. Nope. Yeah, her mic was just working. We were just going through the practice, and it just seems like when it was time for the actual webinar that the mic
Can you hear me
out.
now?
Yes, we can.
Okay, I'm glad. Yes, I was having microphone problems during the week, and I got on a different computer, so I don't know what just happened, but hopefully that will not happen again. So I apologize for that. Let me get my slides up, and we will get this webinar started. Okay, I will take care of that floating box. And there we go. Okay, well, thank you everyone for having me today. I'm really excited to spend the next 45 to 50 minutes with you and to having a robust discussion on how what we're going to discuss today can apply to your own communities. So our agenda for today is on the screen. We will review the incidence and prevalence of serious illness in the United States, discuss the toll of chronic illness on patients and families and communities, as well as health systems, and consider early intervention and contingency plans for patients with serious illness. And then we'll also review advanced care planning in serious illness. And I know that not everyone here will be in a position to actually construct advanced care plans with individuals or in communities, but I want you to have the information in case you want to do any education or programming in your community on this topic. So with that, let's get started on our first topic, which is incidence and prevalence of chronic illness. So serious illness in America, in 2024, the CDC estimated that 129 million Americans have at least one chronic health condition, such as heart disease, cancer, diabetes, obesity, and/or hypertension. Many Americans are actually living with multiple chronic illnesses. So this is a widespread problem. Anyone who has anything to do with healthcare is going to encounter individuals with one or more of these chronic illnesses. These chronic illnesses are all related to the top 5 causes of death in the United States. And those top 5 causes of death in 2023, according to the CDC, are heart disease, cancer, unintentional injury, COVID-19, and stroke, or CVA. And all of these top 5 causes of death are related to preventable and treatable chronic disease. Over the past 20 years, we have made some improvements in prevention, but despite increased sustained efforts to address the social determinants of health and improve access to preventative care, the incidence of chronic disease is still climbing. Also, because of our advances in medical interventions, we have many people living much longer with multiple chronic diseases and living in more debilitated way. So let's take a look at, now that we know these numbers, how does chronic disease actually affect individuals, families, communities, as well as the health systems? So the impact of chronic disease on individuals is very complex and it's multifaceted. For someone who has chronic disease, the chronic illness takes center stage in the person's life, altering the ways that a person can engage in the world. Chronic debilitating illnesses affect the activities of daily living for the individual, such as the ability to work, drive, eat, sleep, regulate emotions, and it also impacts the individual's mental health. A person's ability to engage in their work is affected, and sometimes a leave of absence is required. So, as we know, for adults, engaging in our work helps us to establish our identity. So, this one aspect of chronic illness affects the person globally in terms of how they view their worth, their position in society, and their position in their families. Chronic illness also affects how a person engages in their hobbies, their exercise routines, entertainment and downtime, and also the quality time that they can spend with loved ones. It can also interfere with the person's spiritual life. So when we think of all of these things put together, we can very easily see that chronic illness can impact all of the things in one's life that give one's life meaning. In terms of the effect of chronic disease on family, the overall function of the entire family unit is changed when serious illness occurs for one member of the family. Due to the fear of debilitation, changes in family dynamics, and uncertainty, family members may also experience emotional dysregulation that can then affect the entire family system. So as we know from community health theories and family theories, that a change in one member affects the change of the entire unit. These changes then in turn can lead to increased interdependence. It can stress the family system, leading to conflict and potentially abuse. Or in some cases, depending on the resilience of the family, it can actually lead to growth in new ways. Restructuring of family roles may occur as family members begin to take on roles as caregivers or providers. Maybe if the person who has chronic illness is no longer able to work or needs to take a leave of absence from work, another family member is going to pick up employment. Sometimes chronic illness can actually damage the family, and that family members may abandon the family unit, feeling like this is just too much of a burden for them to be able to deal with. Financial turbulence and uncertainty also occur if the affected person is the debilitated person and they can no longer provide for the family or family members. And that financial instability can affect all of the family, but it can also have an effect specifically on children in the family in terms of their ability to attend school or college. The financial burden on the family is usually related to medical treatments, medical supplies, transportation for treatments or medical appointments, including food. is a financial burden, especially if the person now has to have a modified diet or supplements. And also the cost of medications causes a severe financial burden, particularly if work is disrupted in the household and finances are disrupted. And these costs of medical treatments in the face of chronic illness, these are long-term fixed costs. These are not costs that are going to go away. So this is something that the family has to adjust to together and restructure and rebound from as a unit. In terms of the health system, the burden of chronic disease in the US is staggering. The total budget in the United States for healthcare each year is 4.1 trillion with a T dollars. And of that 4.1 trillion, about 90%, or what would translate to $3.7 trillion, are spent each year just on the management of chronic diseases. Besides the financial cost, there is also the cost of having increased demand for medical supplies, which also increases our entire economy because we depend on other countries for so many of our medical supplies because they're manufactured elsewhere. And although most Americans, according to the US Census Bureau, 92%, although I find that number a little difficult to believe, of Americans do have some form of health care coverage, that was as of 2023, the amount of coverage, the cost of copays, and the cost of deductibles will vary. And in some cases, those costs can be very high. In many cases, the cost on health systems is particularly burdensome because healthcare organizations may not receive full payment for the services that they rendered. And so healthcare systems actually can buckle under the loss of billions of dollars a year annually for that uncompensated care. So we can certainly see, as we're looking at the effect of chronic disease from an individual level to a family level to a health systems level, this is something that is widespread in the United States and affects our entire population. So one of the things that we know about chronic care of chronic illness is that our services are not well organized in the United States, and we have poor coordination of services. So what I'd like to talk about for the next section is the coordination of care. As you know, much of the work in public health, sorry, I bumped a button. Much of the work of public health is wellness focused, and it has been directed on reducing risk factors, including public education campaigns and reduction of socioeconomic disparities. So again, although these interventions have been highly impactful, little attention has been given to leveraging community resources and raising awareness of the trajectories of serious illness within the communities. So to this end, the remainder of the presentation will focus on coordination of care and support for those with serious illness in our communities. So with that, I do have a brief video, and I'm going to stop sharing, and Ashley will pull that video up for us.
See my screen okay? Okay.
Yeah, I can see it.
She's 52 years old, and she is one of about 100 million Americans living with multiple ongoing health problems. May and her husband take care of her father and their children. She works full-time, and today she's got to leave early to catch the bus for a medical appointment. May is tired. Patients with multiple chronic conditions have frequent healthcare appointments that can complicate an already busy schedule. The amount of information coming from many sources can be overwhelming, confusing, conflicting, and impersonal. Different clinicians offer different treatment plans and advice, and there is often little communication and coordination between them. Clinicians do not have the information and tools they need to best support people with multiple chronic conditions. As if May's hypertension and arthritis aren't hard enough to deal with, she also lives with depression, which comes with yet another appointment and another plan for treatment, adding to a life which is already complex enough. But what if there were just one care plan, created just for May and with May? One plan that would treat her as a whole person, rather than focusing on each of her separate conditions. A plan that's created by her care team, with May and her family, that's easy to understand and is agreed upon by everyone. Like everyone, patients with multiple chronic conditions deserve a better healthcare system, one with less confusion and better coordination between clinicians. Working together, we can transform the healthcare system to serve the whole person with all their complexities. It will take everyone, clinicians, researchers, policymakers, patients, and families, working together to get it done. This is May.
Oh, sorry. All
It's
right.
okay. We wanted to be reintroduced to May. It's all right.
Just in case you didn't get the first time around.
Just in case you didn't catch her name, that's okay. Thank you for sharing that. I appreciate it. And I'll head back to the slides. And as I am opening these up, I'll close my little floating bar. I wanted to introduce that video because I wanted to frame what chronic conditions, the impact of chronic conditions on individuals. And in that video, you can see that most people have other responsibilities in their lives. And some days when a person has chronic illness, they may feel pretty good. Sometimes they may not, but you also have the burden of multiple appointments, multiple specialists. The chronic condition then may lead to other mental health issues like depression, which now, again, there's another plan of care. So the question for our communities is, how do we start to coordinate some of the care that patients are receiving when they have chronic illness? How do we intervene earlier to prevent other exacerbations of their chronic illnesses? And how do we develop contingency plans? So in the long run, when anyone has a serious debilitating chronic illness, at some point, the individual and or their family, along with their healthcare team, is going to have to make decisions about, what do you want to do when these symptoms become very debilitating, or when you are to the point where you need to have serious medical interventions. So we're going to take a small turning point here and talk about early interventions, coordination of care, and then we'll pivot once again to thinking about the long-term effects of chronic illness and planning for end-of-life interventions. So we'll start with coordination of care, and this has been a blind spot in the US healthcare system for quite a long time. There are some interventions that are bubbling up that have been available for several decades, but really weren't embraced entirely until COVID came along, and we had to use some of these interventions. Now, some of these interventions are being used more frequently, but because of some of the regulations around telehealth and other distance healthcare provisions, these might not be available for all insurances in the future. So, as we know, most patients who have serious illness are usually treated in offices, in person, on an as-needed basis. So an individual may have an appointment with their healthcare professional every 3 or 6 months, and then they would be seen episodically if they have an exacerbation of their chronic illness, such as heart failure or chronic obstructive pulmonary disease. In between those visits, the patient may also have many symptoms that they may require hospitalization for. And sometimes that hospitalization is unnecessary. If we were to catch things a little earlier, we could treat the person in place at home, which is much better for the individual and their family, and also for the healthcare system. So as we coordinate care, we really want to make sure that we are utilizing and building these community health nets out there so that we can bridge the gap between healthcare visits for these patients. We also want to improve education regarding the disease trajectory so that people know what's going to happen. What can I expect? What is normal within the limits of my disease and what is not normal? What are the potential symptoms that someone might have with a particular chronic illness? And then how will those symptoms be managed? And at what point do I need to go for some kind of emergency care versus do I have a nurse navigator or do I have a healthcare professional through my insurance company that I can contact? So some examples of home-based or community-based services that enable monitoring between visits with primary healthcare providers include telehealth visits. There are distance monitoring interventions like CardioMEMS. And that particular intervention is an intervention where the person who has heart failure can be monitored from a distance by their healthcare providers. Telehealth monitoring, such as blood pressure, weight gain, pulse oximetry. These are interventions that patients can have at home so that we can catch things early. If someone gains a couple of pounds in a day, then we know that if that person has heart failure, they're probably having an exacerbation of heart failure. And these are things that then we can intervene quickly and perhaps save that person a hospitalization. There's also distance pacemaker monitoring, which helps to ensure that the person's pacemaker is working properly, avoiding problems before they start. And then there are also home visits, nurses and other healthcare professionals who can monitor this person and make sure that things are going well in the home. I have provided a resource list that Ashley said that she will share with everyone, and it includes information for healthcare professionals on telehealth monitoring. So there is some information on how to start telehealth monitoring, how to work with patients who have home monitoring in place, how to raise awareness of the resources for home monitoring. But in addition to those, excellent resources for communities are the veteran services. The VA has wonderful telehealth services available for veterans. And also insurance plans are now starting to develop telehealth as well as in-home services. And I'm not plugging any particular insurance company, but if you live in an area that has Geisinger 65 Forward, they have a program where there are regular visits to older adults in the community. And again, these are sort of check-in visits, getting ahead of exacerbations. And if you don't have that plan or a similar plan in your area, a good resource to see what is available would be the area on aging in your community. So as we think about coordinated care, this is something that many insurance companies have found is cost effective. It also helps the member of the insurance company to, again, be able to know what is part of the exacerbation of their diagnosis and what is something that they should be really concerned about. So many insurance companies are offering home-based visits on an annual or as needed basis. And these are, you may see them also referred to as HRAs, and these are health risk assessments. So someone from the insurance company, typically a nurse practitioner, will go to the home, complete an entire head-to-toe assessment of the individual, review all of their medications, make sure they're not taking medications that they no longer need to take, or that they are not taking medications that they do need to take. So we'll do a complete medicine reconciliation. And through that one point, through that home visit, other referrals can be made to home care nurses, nurse practitioners. Perhaps this person needs something like a social worker referral for Meals on Wheels. Perhaps there are some services through their faith community. All of these things can sort of bounce off of this one platform. There are also coordinated care models inside of nursing homes and assisted living facilities. So if you have community contacts who are in any kind of facilities, then one way to check to see if there is more assistance available is to check with their insurance company to see if they have any coordinated care models in place where they could receive extra visits from nurses or nurse practitioners affiliated with their insurance companies. The goal of these coordinated care models is early recognition of exacerbation of chronic illness and early intervention. So, as an example, if there was an individual who was living in a skilled nursing facility who had chronic obstructive pulmonary disease, and that person suddenly started to have a loose cough and was having a fever, the nurse practitioner from that insurance company could see that person and treat that person's exacerbation rather than sending the person out to a hospital for treatment. And again, it saves money for the entire healthcare system because we're now treating in place rather than using acute care services. But in most cases, it is also better for the individual, especially if the person has some overlying dementia symptoms as well, so that we're not moving people around when they don't need to be moved. So this is our coordination of services models. But we also want to talk about chronic care management. So we have individuals who have chronic illness in facilities, in the communities. We want to coordinate our services through insurance companies is one of our newer models, but also again through organizations such as the Area on Aging. And we also want to think about the advanced care planning portion of having a chronic illness. So that will be the last section that we talk about today in our presentation. Educating patients and families in the community about disease trajectories is a very high priority for folks who have chronic illness. So if you are in a position to provide education for folks who have chronic illness in your community, this is one of the things that is really important for people to know so that they can sort of see the path of what their chronic illness will take. So you can see all the way on the left-hand side of your screen, there's functional ability that goes from high to low. Oops, sorry, I forgot I had a touch screen. From high to low. And then across the bottom, this is time. So if you look at that top line where it says colon cancer, this could actually be any kind of cancer. So usually with a cancer diagnosis, the person does really well for quite a long time. You might see sort of a slight decline, and then you start to see that little curve of decline and then a rapid decline toward death. CKD is chronic kidney disease. So you can see that these patients do really well. And actually, many times, individuals who have kidney disease, there comes a time when the individual and or their family might feel like, wow, they're doing really well. I don't think that they're really that sick. But you can see where they hit a point, a turning point in their disease, particularly without dialysis, where they also have that steep decline. So you can see that with cancer diagnoses and with kidney disease, you have these periods of the person is doing all right, and then they quickly decline. With chronic illnesses like congestive heart failure, COPD, which is chronic obstructive pulmonary disease, or end-stage renal disease with dialysis, you can see these periods where the person is relatively stable. That's that flat line. Then they have a period of decline, but they are treated, right? So this person was going to go to the hospital and have treatment, and they're going to bounce back, and they're going to have a period where they're pretty stable, and they may have another exacerbation and be treated and bounce back, have another period of stability, a period of exacerbation, bounce back, another period of stability, and so on. And you see that pattern. So it's a chronic illness with periods of exacerbation, but what you notice in that line is that that line is steadily going downward. So what that means is that every time that person bounces back from an exacerbation, they don't bounce back to the same level that they were at before the exacerbation. So this is important for individuals and their families to know that when they have an exacerbation, it's very likely that they're going to bounce back, but they're going to lose some ground in terms of functionality. They may not feel as well after that exacerbation overall when you look at the larger picture. And then you see on the very bottom diagnoses like frailty and dementia. And this trajectory sort of wanders toward a declinatory picture from beginning to end, but there are no really steep declines and bounce back, and there's no real fast decline like you see with cancer and chronic kidney disease. Folks who have dementia or frailty have a slow decline over time, where you notice that they need more help with activities of daily living. They need more assistance with getting dressed, choosing appropriate clothing, eating, getting out of bed. All of these things are changes over time, but there's no one real turning point like you would see with a cancer diagnosis or kidney disease without dialysis. So these last two trajectories are trajectories that seem longer for families and individuals in some ways, because the person, you don't really see that sharp turning point that you see with other trajectories. Knowledge about these trajectories is extremely important in terms of planning for medical care. The person who has any one of these chronic conditions needs to know what it's going to look like in the long run so that they can think about what interventions they may or may not want in the future, and at what point do they want to make those decisions. So this is where we will start talking about advanced care planning, and anything that has to do with death or dying is usually an uncomfortable topic in communities. But this information is so highly important that I really would encourage you, from whatever standpoint that you're at in your professional roles, if there is a way to share this information with the communities that you serve, it is very important for people to be able to make their own autonomous decisions based on their knowledge of the chronic condition that they have. So with that, we'll move into discussing advanced care planning, the types of care plans that are available, and what might be the best choice for different populations. So overall, as we talk about advanced directives, sometimes there is confusion about what an advanced directive is, the legality of it, when it can be honored, when it can be changed. So this little image here gives us the umbrella term of what an advance directive is. It is a legal document that patients design to make their end-of-life wishes known in the event that they are not able to communicate on their own. Advance directives come in two varieties: living wills and medical power of attorney. So the living will you see on the left-hand side. This is a written statement created by a patient when they are well that communicates the type of care they would want if unable to communicate due to illness. This type of advance directive only becomes effective if the patient is unable to express their own wishes. So the living will is something that someone can think about and plan for upstream in their diagnosis, right? So if this were to happen to me, I would want this. If this were to happen to me, I would want that. This isn't really the type of document that you would want to wait until the person is very, very ill to put together, but not everyone wants to do this. Not everyone wants to create a living will. So as we're talking to individuals, families, or communities about creation of a living will, it's important to emphasize this first sentence, that the living will is created when the person is well. So we have to be of sound mind, thinking about what we would want in the event that something would happen to us. When people think of chronic illness or proximity to death, we often think of those people who are closer and those people who aren't, but the reality of it is that nobody knows. So creation of a living will is something that is important for everyone to put together, no matter their age or no matter if they have a chronic illness or not, because this is something that we don't know when it's going to be needed. The medical power of attorney is also, it's on your right-hand side of your screen, is a type of advance directive in which the patient designates another person to make medical decisions for them if they are unable to make their own decisions due to illness. Other terms that are used interchangeably are healthcare proxy, surrogate, and healthcare agent. So the medical power of attorney comes into play if the person can't make medical decisions, and that could happen for a variety of reasons. The key issue to communicate to individuals, families, and communities is that when they are going to choose someone to be their medical power of attorney, it should be someone who is willing and able to honor their wishes, especially if they have them written down in a living will. Because often what happens in clinical practice is that there's an event, someone is very ill, they can't make a decision, and then the healthcare professionals are trying to scramble and find out, what does the family know about this person's wishes? Is there someone who can make decisions? And legally, there is an order to who is going to be the decision maker. But it's important for people to think this through ahead of time, because that person who may be your legal surrogate may not be the person that you want making decisions for you. So these conversations are important between individuals and their loved ones for a person to be able to say, if this thing were to happen to me, this is what I would want done. Would you be willing to do that? And if that person can't say yes, then the patient needs to find someone else to be their medical power of attorney, because the medical power of attorney is really the person's voice when they can't make their own decisions. So with that information, we're going to talk about different types of living wills. And these are all advanced directives that we can teach communities about to help them, again, make their own autonomous decisions. So the first one that we'll talk about is a POLST form. Depending on where you live or how familiar you are with these forms, in some places they were called physician's orders for life-sustaining treatment. In other places, they were called providers' orders for life-sustaining treatment. In some states, they were called MOLST, M-O-L-S-T, medical orders for life-sustaining treatment. More recently, these forms are only called POLST, P-O-L-S-T, and it's not an acronym anymore, it just is POLST. And you can see more information by going to nationalpolst.com. And what you will find there is information about the use of a POLST form, how to complete them, and why they are really important for individuals who have any type of chronic illness who are nearing that end part of their trajectory. So the POLST forms were created for individuals who have a prognosis of about a year. Now, of course, no one has a crystal ball, but around a year, someone who has a chronic illness These are the people who would want to have a POLST form in place. So as you can see on the left-hand side of your screen, this is just an example of a POLST form. There are other types. The POLST form is a type of advanced care plan where the person is asked whether they would want to have CPR, what interventions they might want. So they are asked whether they would want full treatment, which means intubation, airway interventions, mechanical ventilation, cardioversion, etc. They could also choose only some of those treatments, or they could choose only comfort measures to relieve pain with medications, use of oxygen, etc. And if they have specific things that they do or do not want, they can add that under additional orders. The key to the POLST form is that it is signed by a medical professional. It's signed by a provider, which is a physician, a nurse practitioner, or a physician assistant. So the POLST form comes into play when someone is at home and EMS is activated. Typically, if EMS is activated and they come into the home, if there are no living wills that are signed by a provider, then EMS must take measures to sustain that person's life, such as CPR, starting IVs, etc. The POLST form provides a medical order which enables EMS to be able to follow the wishes of the individual. So these forms are very important for people who really want to have the interventions that they want to have and no other interventions. POLST forms are usually written on brightly colored paper, like this bright green or hot pink sometimes. And if someone has this form in their home, they need to put it somewhere where it can be seen by EMS. So POLST recommends that it is placed on the refrigerator. And of course, this is a sensitive document. You may not want to look at your end of life wishes every time you want to go to your refrigerator and get a cup of yogurt or something. So you can advise individuals to put it in a brightly colored envelope on the side of the refrigerator, or just in an envelope and write POLST on it. That's the recommendation for where people should keep them. EMS is aware that this is a place to look for them, but they can be placed in other places where they can be seen as well. The key here is that the POLST form is a medical order that goes with the person where they go. Another type of advance directive or living will is this document called 5 Wishes. And 5 Wishes is, it's a little booklet, and this is the website for it. You can go on there and see a sample of it. And it walks individuals through thinking about what they would want in terms of medical care, spiritual care, community help, and it's in plain language. So it's very easy for anyone to be able to take this booklet, read it, and note their wishes in. Some providers, healthcare professionals, will offer this booklet to patients and walk through it with them. Sometimes providers will offer it to patients to do it on their own and bring back to the office. The 5 Wishes document is recognized as a living will in, I believe it's 47 states now. There are a few that it's not, but even in states where it's not recognized as a legal living will, it still offers the questions that people should consider when they're thinking about what interventions do I want or not want. And again, working through these questions ensures that the person receives the type of care that they would want, but it also ensures that the patient, the family, and the healthcare system are not overburdened with interventions that the person never wanted in the first place. So this is really all about autonomy and getting the right care at the right time for yourself. Another aspect of care at end of life that is really an important resource in all communities is hospice care. Now, hospice is different from palliative care in that palliative care is symptom management and should be integrated into chronic illness from the very beginning. So as soon as someone is diagnosed with a chronic condition, palliative care should be on board to manage symptoms. Hospice care is community-based end-of-life care. That means that we are looking roughly at the last 6 months of a person's life. But again, no one has a crystal ball. That's what Medicare says, 6 months. But there are people who are on longer, who are on for a shorter amount of time. There are eligibility criteria for hospice, and I did add those to the resource guide that I provided. So you can look through those. There are eligibility criteria for multiple diagnoses, cardiac disease, lung disease, dementia, kidney disease, pretty much anything that you can think of, stroke. And those criteria help healthcare professionals determine when this might be a good resource for an individual and their family. And what's important to note with hospice care is that the individual and their family are viewed as the unit of care. So the family receives support just as much as the patient does. And there is also bereavement care for the family after the person passes away for up to a year. So this is a really nice resource that's available pretty much in everyone's community. It is covered by Medicare. And for those who are not eligible for Medicare, many insurances also cover hospice care as well. So this is a nice resource to keep in mind for individuals who are at those later stages of chronic disease. When we are thinking about chronic disease in terms of public health, our role is to understand the scope of chronic illness and how it affects the individual, the family, and the community as well. It's also our role to identify resources in our own communities, such as telehealth, home care, and insurance programs that can offer services to underpin the care of individuals with chronic disease. It's also our role to educate the public on disease trajectories. As I noted earlier, we do spend a majority of our time focusing on primary care, primary prevention, which is extremely important, and that is wonderful work. We also need to do a little bit of work on the other side as well, so that people who have chronic diseases know what to expect and how to stay well within the context of those chronic diseases. And it is also our role to raise awareness of what are the services that are available for the end stages of chronic diseases, such as hospice services, and also raising awareness of how individuals and families can plan for the type of care that they would want when the chronic illness runs its full course. By coordinating our efforts, partnering with medical structures, and educating communities about chronic illness, we can mobilize necessary resources for patients and families, empowering autonomous decision-making. And I'd like to thank all of you for being here with us today. This is certainly a topic that I'm passionate about, and I hope that you have gained some nuggets of information that you can share in your own communities. And I'm happy to take any questions that you may have at this time.
All right. Oh, there we go.
There you are.
I keep turning it on and off.
That's okay.
So we do have a couple questions.
Okay.
And like I said before, if you have specific questions, please put it in the Q&A section so I make sure I catch those. So starting off, first question is, can home health be used for people with chronic illnesses?
Okay, that's a great question. So thank you for that one. Home health services are separate from hospice services or other insurance company initiated services. Home health services are specifically designed for people who have what is called the medical need, a medical necessity. So a chronic illness such as COPD or heart failure would not necessarily be enough to qualify someone for home health. we would be looking for something more like, does the person have a wound that needs to be cared for? Does the person need IV antibiotics? Is there some skilled need that the nurse needs to provide for this individual? So I don't want to say just because someone has a chronic illness, because it certainly is a heavy burden, but that is not enough for someone to receive consistent home health care from nursing staff.
Okay, great. Thank you.
Mhm.
Our next question is, what happens when a patient changes their mind regarding what they've mentioned in their living will?
Oh, that's a great question. So, people can change their mind about what's in their living wills at any time. So if you have a living will and then you decide, you know what, I said that I didn't really want that, but now I do. As long as you can communicate that, you yourself can change your living will. Where it gets tricky is if the person can't communicate that. And that's when you would have someone who would be your medical power of attorney, advocating for you, hopefully knowing what you would want. But yes, you definitely can change your mind about what's in your living will.
Great. Okay, this next question, I'm not sure I understand the context, so if we need to ask for more context, we will.
Okay. Okay.
It says, is it automatic to help people get disability? Why is it difficult to get that in order to slow down the burden?
Oh, that is a great question. So I wish I could have an answer for that one, because it is definitely financially burdensome, as I discussed, to individuals and families when there's a chronic illness in the family, particularly if that person was the breadwinner, the person who's paying the bills. Disability services, I'm assuming what you mean is the financial piece. It can be very hard to get disability compensation through employers. People usually have a better chance of getting like short-term disability or even long-term disability. But then when that person has to transition over to government services for disability, that's when it gets really hard. If possible, I would always recommend that the individual seeks legal advice to be able to have someone to coordinate, the medical pieces as well as the legal pieces that they need to move forward for disability compensation. That is a serious problem in our system for supporting people who have serious illness. I wish I had a better answer. I don't have any words of wisdom to say, well, if you did X, Y, and Z, it would help move that forward, because there just isn't. It's very challenging.
Yeah.
But I
All right.
appreciate you thinking of that, because that is, really empathetic perspective.
Yeah. All right. The next question is a two-part question. So
Okay, lay it on me.
a little bit long.
Okay.
What care coordination exists outside of insurance companies when a patient has many specialists and care plans? Is there someone who can coordinate with the specialist on the behalf of the patient?
That is a great question. And I would love to be able to say to you, yes, here's this person that you didn't know about who could do this. Unfortunately, right now in 2024, the person who is coordinating a lot of that is someone who works for the insurance company, which you can see is a double-edged sword, right? Because their main goal is to save money. And yet there also is this other side of, we want to provide the care that the person needs. So that's your coordinator. In the medical model, you would like to think that the primary care physician, nurse practitioner, or PA is the person who is coordinating all of these efforts. And in many cases, that is the person to turn to. So their primary care physician, nurse practitioner, PA is the person who is getting all the results from all of the testing, pulling everything together, and looking at the bigger picture. In some cases, you may be able to connect the person with a nurse navigator within your local healthcare system, and that person will be able to help coordinate services, Social workers in healthcare systems are also excellent case managers and case coordinators to help bring those services together. But as far as there being a role for a healthcare person to be assigned to every patient and help them manage all of this, there's just not an easy answer for that. There's just not that role that is widespread. Some people here might know of those roles in your own healthcare systems. So if you do, please share that. But across the country, it's pretty sporadic.
Okay. All right, next question is, are there services to help older adults with cooking, cleaning, and bathing?
Yeah, thank you. That's a great question. So there are services out there. If you find that there's a need in your community, I would contact the Area on Aging, and they will be able to tell you what's out there and help connect you with the services. So for example, in my area, and this could be different in your area, the Medicaid and Medicare contracts for homemaker services, non-medical care, such as bathing, cleaning, cooking, etc., are contracted out to an agency. So in my area, that is Caregivers of America. And that organization will meet the needs of individuals in by using government grants, by using government funds to provide nurses' aides or homemakers where they are needed in the community. So your point for that is Area on Aging. They will be able to help you figure out where those contracts are in your area and how to get those services coordinated. Oh, and one other thing that I should say is that if you have someone who's on hospice, everything is covered under that hospice Medicare benefit. So the person is entitled to nursing visits, nurse aides, homemaker services, all of their medications that are covered. All of their medications that are related to their terminal illness are covered, as well as any medical equipment that they need. So depending on where they are in that chronic illness, if they're eligible for hospice, hospice services takes care of all of that. But if they're not there yet in their trajectory, then that's where you would look into other services through Area on Aging.
Great. All right, this is going to be our last question.
Okay.
So, what resources are available for patients who can't afford their medications?
Oh, that's a big question. Okay. So the first place that I would look is I would look online for GoodRx, G-O-O-D, GoodRx. You will find little cards in pharmacies, at doctor's offices, and these little cards have numbers on them. And when you go to pick up the prescription from the pharmacy, you need to know whether it's a participating pharmacy. And if you show that card, the patient will get a pretty significant discount on the medication that they are picking up. It's some program that's associated with most insurance companies. So you can definitely look into that. That's an excellent program for individuals who are paying for medications, either out of pocket or even with copays. Another place to look is in your community to look for any stores or pharmacies that offer $4 prescriptions. These used to be much more common, but there are still, some places have gotten rid of it, but some places still have it. I believe Walmart still has the $4 prescriptions, possibly Walgreens. You'd have to check with, in your area to see where they are offered. But the medication, regardless of whether the person has insurance or not, will cost $4. The key here is that if someone has insurance and they want the $4 prescription, they have to say, charge me like I don't have insurance, because otherwise they'll pay the copay for their, for their insurance company, which is usually $10, $20, whatever. Some other ways to decrease cost are to talk to the pharmacy about drug company cost reduction programs, because sometimes they can offer funds for individuals to be able to access their medications a little more easily. And there was one more that I was thinking of. Of course, it will come back to me after we get offline, but they're the main ones. They're the big ones.
Great. All right. So thank you so
Copay
much.
assistance programs. Yes. Thank you. Thank you. Copay assistance. I'm like, I know there was another one. Yes. Yes, there
Thank you,
are some
Megan.
copay
Yeah.
assistance programs out there. Yes, thank you for that.
Yeah. All right. So thank you everyone for being here today. A special thank you to Dr. Wright for taking the time and teaching us about this topic. So I hope to see everyone next month at our next webinar Wednesday. We have them every second Wednesday of the month. So please go to the NBPHE website and go to the webinar Wednesday page and check out what's coming up. And as I said at the beginning of the hour, I will send you all an email with that resource link that I shared in the chat. So thank you once again, and I look forward to seeing you again soon.
Thank you, everyone. Have a great rest of the day.